Okay, so hello everyone. Today is OSCE Masterclass number 7, I think we're up to. I asked people what kind of surgical examinations they want to go over that we haven't been over yet. I've been asked to do the vascular exam, so the peripheral arterial exam, and the venous examination as well. Before we start, I just wanted to say that if you've paid to watch this, this is free. Some people keep advertising on our page all these links that you have to sign up and pay for. Please don't do that. If you're doing that now, don't do that again. It's free. You can just contact us and get a ticket for free. You can get it last minute. Having said that, we do this for free, and the only thing that we ask for is feedback. You will get a certificate if you complete feedback, and it's really important because it helps us improve, and it's the only proof that we have that we're actually doing this teaching, so it's really important for us. As I mentioned, all of the talks that we give will be on YouTube eventually, so keep that in mind if you decide to unmute yourself. I know I'm a bit behind on uploading the talks because I've been put on a surge rota, but hopefully that will stop soon and all of the videos will be uploaded. If you've got any ideas on what else you'd like us to cover, please do let us know. These are some things that I came up with that I thought might be good to cover. But it's up to you guys. What I mean is as part of the OSCE series, but if you want us to cover other topics, generally we're happy to do that as well. So this is the list of topics that I thought might be useful. So my name is Natalie. These are my credentials for those of you who need to log this as part of your learning. Today we're going to go over the arterial examination and the venous examination. You can find lots of videos of people just going through the OSCE online. So we're not going to do that and it's COVID, so I need to be able to find someone in my household who's willing to let me examine them, which is not going to happen. So I'm going to explain the OSCE to you. This is going to be the time to explain the principles behind it and demystify any confusing parts as well. In terms of resources, I've put this first just in case you do want to watch the OSCE. OSCE Stop, OSCE Aid, and Oxford Medical Education are all really fantastic. They go through things in really good detail and include loads of videos. Almost a Doctor is also really good, as is Geeky Medics, and Teach Me Surgery also goes through a lot of theory, which is really useful. So I would use all in any mix of these as resources. So first I'll go through the arterial vascular exam. I'm going to go through some background information that you need to know. So I'll talk about what peripheral arterial disease is and how it's split into the chronic and acute types. Then we'll go through the OSCE. What I'm going to keep repeating here, and you'll be sick of it, is that each OSCE has an open, has the bit that you do to examine people, you go through your special tests, and then you've got your closing part. So peripheral arterial disease, what is it? It is the narrowing of peripheral arteries supplying the legs, stomach, arms, and head. It usually starts in the legs, partially because the arteries are longest to get there, which is why we usually concentrate on the legs. It's caused by, amongst other things, atherosclerosis. This is blockage of the arteries with plaques made of cholesterol, fatty substances, calcium, and fibrin. And this little image here shows what it is. So initially you've got this nice tube with really good blood flow through it. Then it gets blocked up by all this horrid stuff. The blood flow isn't as good. These plaques can block things off, so they can block things off slowly, and they can also break off and block things off further down the line. That's really important. We'll talk about why that is in a bit. Risk factors for peripheral arterial disease include diabetes, so diabetes mellitus, hypertension, high lipids, so high cholesterol, a family history, smoking, and also the risk of it goes up with age. In terms of dangers of peripheral arterial disease, it leads to pain, but it can also lead to gangrene, so you can lose bits of limb from it. It's also the atherosclerosis that takes place doesn't just take place in the legs and the arms, it also takes place in the heart and in the brain. So it's associated with coronary artery and cerebral vascular disease. So if someone comes to you with peripheral arterial disease, they've probably got a lot going on. Someone's managed to unmute themselves. I'm just going to mute them quickly. Logan, are you all right to do that? Okay. And it's split generally into chronic arterial disease and acute. So in terms of your chronic arterial diseases, and it happens over a long time, people come to you presenting with something called intermittent claudication. This is pain in the muscles due to poor blood flow. What they'll say is, oh, whenever I walk a certain distance, my legs start cramping a really, really abnormally high amount. It really hurts. I have to stop. I can't keep going. I stop for a while and then I'm able to go again, but then I have to stop again. One thing to remember is that if they complain of pain in the calf, it's usually the femoral artery that's blocked. If they complain of pain in the buttock area, it's usually the iliac artery that's blocked because that's where it supplies. There are loads of different ways to manage it. You've got your conservative management, which is stuff like education, exercise programs, diets, weight loss, quitting smoking. You've got your medical management, so you can manage the risk factors by giving stuff like aspirin, statins, antihypertensives. You can also give vasodilators that are specific for this, but they're super rare to give because they have lots of side effects. You can also do interventional radiology. That's what IR here stands for, which is pretty much them sticking some contrast down so they can see what they're doing. They then stick a wire down, inflate a balloon, and leave behind a wire mesh here that keeps the artery nice and open so it pushes all that nasty stuff out of the way. You can also do surgical management, which is kind of similar to IR, except for they actually cut down until they see the artery, find the blockage, and kind of do this balloon thing, but under direct vision. This was to illustrate why the different blood supply causes different kinds of pain. So you've got the iliac arteries here, they'll break off to supply the buttocks. So issues here will initially cause buttock pain. You've got the femoral artery here, which breaks down to supply the calf as well as other areas, but they'll initially complain of calf pain there. Other things to know about chronic peripheral arterial disease is the concept of critical ischemia. Critical ischemia is just a term we use that indicates severe reduction in blood flow to the extremities. It's when you start worrying about there being ischemia, so death of tissue. There's a few different definitions. The ones that you guys might be asked about in your OSCEs are pain at rest over more than 2 weeks, or necrosis and gangrene with an ABPI less than 0.5. I will tell you what an ABPI is in a moment, or an ABPI less than 0.3 by itself. An ABPI, which I will go through in more detail later, is a rough measure of your blood flow to your legs versus your arms. So if the blood flow in your legs is much worse than the blood flow in your arms, you know there's some kind of plaque stuff building up. People will complain of burning pain at rest, nocturnal pain, and it's better when they kind of hang their legs over the edge of the bed because gravity pulls the blood flow down, so the end of the foot gets a little bit better perfusion. Now we've moved on to the acute arterial disease. With acute disease, you've got thrombotic and embolic disease. And you've also got other, but that's very, very rare. With thrombotic disease, it's just the thrombus, so that plaque getting bigger and bigger until it suddenly blocks off the artery altogether. With embolic, you've got stuff flying out into the artery and blocking it suddenly. So you can have that in atrial fibrillation. You can have it after an MI, after a myocardial infarction, because the heart's not pumping very well, so you get little clots building up in the heart that fly off elsewhere. You can also get clots forming on prosthetic metal valves, on bypass grafts, and also a paradoxical embolus, so a venous clot, which goes through a hole in the heart called an atrial septal defect. So it manages to get from the venous system into the arterial system and block off an artery somewhere. Other causes include trauma, dissection, so if your aorta dissects, if the inside lining comes off, you end up blocking up arteries elsewhere and causing ischemia elsewhere. Iatrogenic, so I don't know, we've done some surgery and we've managed to block off an artery. And compartment syndrome, this is where there is so much pressure inside that, whatever it is, the limb, even the abdomen, you can get it sometimes, that it blocks off the artery. It's really rare to get compartment syndrome so bad that you block off arteries in the abdomen, because the arteries are huge, but I guess theoretically it can happen. And then you've also got acute on chronic. So basically you've had chronic peripheral arterial disease and then suddenly the arteries blocked off. Right, so the 6 Ps, does anyone know what these are? The 6 Ps of acute peripheral arterial disease, acute limb ischemia. Have a quick look at the chat. Oh, I can see people typing stuff. Pain, paresthesia, pallor, really good. Awesome, you guys are familiar with this. Okay. So these are really important to know. I like to split them into things you see and feel and things that the patient feels and says, just because it helps you remember it a bit better, because there's 3 in each. So you'll have a look and you'll go, oh my gosh, that leg has really, really gone white. There's pallor. You'll have a feel and say, oh my gosh, it's so cold. It's perishingly cold. They've put in the perishingly because there's a P in there and it's the 6 Ps. You'll have a feel and you won't be able to feel the pulses because there's no blood flow. And then the patient will complain of pain out of proportion. Those are the words that people like to use. That is the first sign that people get. And that is when you should already be thinking, oh, why is their leg or their arm hurting so much? That's really weird. Maybe I should think about that. Then you've got paresthesia. So they'll say that their sensation has gone a bit funny, or paralysis. Eventually, they won't be able to move that part of the limb. Paresthesia and paralysis are really late signs. You don't want to be getting to that stage. You want to start thinking about it when they're complaining of pain. As well as the 6 Ps, you've also got 6 hours. So it's thought that you've got roughly 6 hours to salvage an acutely ischemic limb. So once they present and they go, oh, my leg turned white at 6 o'clock, you've got 6 hours to try to get that unblocked and fix it. Otherwise, they might lose the limb. Having said that, the management of acute limb ischemia, immediate management. So if you've got a thrombotic cause, you've got to get something in that and open it up. So the balloon angioplasty that I showed you an image of, where you stick a wire in, you open up a balloon and leave behind a nice wire mesh. You've got your embolic, so a clot has gone and blocked it off. It's kind of similar because you stick a little wire down, but this wire you inject medication into, so you thrombolize it, it breaks up the clot. Or a surgical arterial embolectomy. You basically cut down to the artery, find where the clot is, stick a wire in and pull that clot out. If that's all failed, you might need to amputate. This is an image of the surgical embolectomy. They'll find the artery in the vein, which obviously aren't really blue and red in real life. Everything's kind of reddish down there. Then they cut down, follow it, find where the clot is, stick a wire in and pull it out. Pretty cool stuff. There are some complications that you guys need to know about. So as well as compartment syndrome being one of the things that can cause arterial ischemia, ischemia can actually cause compartment syndrome. So after you've had ischemia to that leg for a while, there's a lot of cellular damage and there becomes a lot of swelling. So what happens is, if you see these dotted lines here and here, whilst the surgeons are fixing the clot, they will also cut into the leg on both sides so that the leg can swell up and it's not restricted by the skin, so that you don't have increased pressure inside the leg. Because you've got the breakdown of muscle cells, you also have something called rhabdomyolysis. This causes myoglobinuria, so little bits that used to be in the muscle cell end up in the urine, which causes massive damage to the kidneys, acute kidney injury. It can also increase your potassium levels, hyperkalemia, and cause a metabolic acidosis. Pretty much the toxins go mental and your body gets very upset by it. This can cause cardiac stunning, so your heart can pretty much get upset and say, nope, don't like this, don't want to do this anymore. And you can also get acute respiratory distress syndrome for similar reasons. Right, that was a lot of background because it's a fairly complicated topic that people don't usually get taught in detail. This is the OSCE overview that I want to hammer into you guys. You've got your opening, which is your wiper. Do you guys remember what wiper stands for? Looking at the chat. Yep. Wash your hands. Introduce. Yeah. Okay. People are getting it. We'll go through it in a second. Then you've got your examination. In most exams, it's inspect, percuss, palpate, auscultate, but there's not really anything to percuss here. So you go inspect, palpate, and auscultate. You do your special tests, and then you do your closing parts. So your opening, you've got your wiper. You wash your hands, and nowadays you also got to remember to put your PPE on as well. You do the introduction, so you introduce yourself and you check you've got the right patient. You ask for permission to do the exam by explaining what it is you're going to do. You expose the patient adequately, so here it would be all their limbs and their abdomen. You reposition them so that you can start. Then you inspect. When you inspect generally, so not just the patient, but what else is around them. And then you have a look at the patient themselves. Can you guys see what these images are? Tell me what you can see, because they might be around a patient that you're asked to examine. Yep, there's a GTN spray that's here for angina. So we spoke about atherosclerosis, which you can get in the legs, you can get it in the heart as well. Oxygen, yep, the patient might be on some oxygen. What's this up here? All right, so we've got someone said wheelchair, yeah, so they may already have such severe claudication that they can't walk. Nicotine replacement gums and a cigarette. A heart monitor, yeah, so this is ongoing heart monitoring. This is insulin here, and this was just me mentioning to look for other medications. Really good, guys. Okay, so remember, always look around the patient first. Make a show of it in your OSCE as well. Lean back, have a look. Make sure that there's nothing there. They like to give you little clues. And then you do the OSCE exam itself. The next slide is going to be really complicated and busy, so I just wanted to go through it generally. You're pretty much looking at the arms, the abdomen, and the legs. You're having a look, you're having a feel, and you're having a listen at each stage. And at each stage, you're going through all of the pulses. Some people get a bit uncomfortable when it comes to the femoral pulse. Just ask your patient or your fake patient if they're happy. And remember that you have to feel for the aorta and listen to these pulses here, the renal pulses and the iliac pulses. Usually I work from distal to central just because it feels nicer that way. It works out a bit nicer for me. You'll find your own way of doing it. So this is the summary of the OSCE. You can start with the upper limbs, have a look at what color it is. Is it nice and pink? You think about what the causes and complications might be. So if they've got diabetes, they may have pinpricks from when they're taking their sugar. They may have tar staining from smoking. There may be tendon xanthomata from hyperlipidemia. They might have scars from previous surgery. Look for any signs of gangrene. Hopefully anyone you see in an OSCE is not going to have gangrene, because that would be concerning. And then you palpate. So one of the reasons I like to start distally is because you can start with capillary refill at the end. Do you guys remember what a normal capillary refill time is? So what you do is you squeeze someone's finger for 5 seconds, drain all of that blood out, and then you let go and watch the color come back. Yeah, less than 2 seconds, good stuff. Everyone's a little bit different. Some people might take maybe 3 seconds, but anything longer than that, I would start worrying that they might be underfilled or there might be something else going on. And then you feel for temperature. So this is a very rough check comparing sides. So you feel both sides at the same time and you work upwards. And at the same time, you can say, I'm just going to touch you on both sides. Tell me if you can feel. And that's your sensation checked. And also ask them, does it feel normal? Because they won't necessarily lose sensation. They'll have an alteration in their sensation. And then you feel for pulses. So you feel your radial pulse, the brachial pulse, and the carotid pulse. Never do both carotid pulses at the same time. Patients can pass out, and the older patients might have a degree of disease. You don't want to be pressing on both their carotid arteries at the same time. When you get to your radial pulse, if you remember to do this here, it's better, just because you'll not forget to do it later. What you do is you do your radio-radial to check for delay. So you feel the radial pulse on both sides and check that it beats at the same time. And the same with a radio-femoral delay. So you feel the right hand and the left leg to make sure that there's no significant delay in the pulse. I'll show you why that is on the next slide. You'll listen for the carotid bruit, and if you can remember, ask for blood pressure. If not, you add it at the end. Then with the abdomen, you look for any scars of previous surgery. You look to see if there is a pulsatile aorta, which you can see on slimmer people usually, and then you feel the pulses. Here, the only pulse that you're really going to feel is the aorta. You put 2 fingers on it next to each other. You've got to feel it pulse, but the fingers shouldn't be forced apart. That indicates an issue, like an aneurysm. And you listen for the aortic bruit and the renal bruit. Then you get to the lower limbs. It's kind of similar to the upper limbs. You look at the color, you look at the skin, you check for scars here. You can also have a look for ulcers. You have a feel for capillary refill time, temperature in the same way comparing both sides, sensation in the same way comparing both sides. You feel the pulses, your dorsalis pedis, your posterior tibial, popliteal, and femoral if the patient is happy for it, and have a listen for femoral bruit. And that's the actual exam bit done. So this is why you do your radial, and radiofemoral delay. This is something called coarctation of the aorta. It's a congenital malformation where there's a narrowing in the aorta somewhere. And that means that the blood flow to the rest of the body is restricted. It is super, super incredibly rare to not have this diagnosed in childhood. So the chance of someone having this in your OSCE is vanishingly low, but it's something that we continue to do. So if they have this here, this narrowing, there will be a delay in the pulse between the right hand, which is supplied by this branch here, and either the left hand if the narrowing is before this, or the left leg if the narrowing is after this. It's quite complicated. I hope that makes sense. If not, we can go over it again later. Then your special tests. So Berger's test. So Berger's angle is the angle to which the leg has to be raised before it becomes pale. What you do is you lie your patient flat on the couch. You ask them, have you got any pain in your hips? They say no. You say, lovely, I'm going to lift your leg up. So you lift it up and you keep the leg straight. So you watch the sole of their foot as you do it, and you wait for the sole of their foot to go white. Hopefully it does not happen, because that is normal and healthy for it to stay pink the whole way that you lift the foot up. But some people have arterial disease, obviously, so their foot turns white because the blood can't flow very well. The less that you've had to move their foot up before it turns white, the more severe their disease is. So what I'm saying here is the lower the angle, so say you've only lifted their leg up to here, the more disease they have. And less than 20 degrees of lifting is meant to be thought of being related to severe peripheral arterial disease. After this, when you found Berger's angle, you swing the patient's leg down off the end of the bed and you watch the sole of the foot. So after finding Berger's angle, you ask the patient to sit up and swing their legs over the side of the bed. Berger's test is positive if the leg turns purple, red, and painful. Reactive hyperemia, also known as the tequila sunset sign. So what happens is that foot that you've just made white, that's become ischemic. That is screaming for oxygen. It's releasing things to try to get more blood flow to it. So when you drop that foot down, those signals are still there. So the blood flow to it is increased, and it will be really, really red and even purple, and they'll complain of pain as well because it's been ischemic. Right, so I promised you guys I was going to talk about the ankle brachial pressure index, a rough measure of blood flow to the ankle compared to the brachial area. How long do you wait with the leg up? You just keep lifting the leg up really slowly, maybe over about 20 seconds. I'm not sure exactly. I will check at the end of this, but that's what I usually do. Okay, so ankle brachial pressure index. What you do is you check the blood pressure. We'll start on this side first, in both arms, and you check the blood pressure in one of the legs, whichever leg it is that you're testing for. You take the highest arm pressure and you take the highest leg pressure, and then you do the leg pressure divided by the arm pressure. I'll go over it again. You use a Doppler probe, which is this thing. It's kind of like a microphone for your pulses. You put some jelly on it and you put it on the pulse. You inflate the cuff until the pulse stops, and that's your blood pressure. You check that in both arms. You check it in the artery that you're interested in on the leg that you're interested in. You do your ankle pressure divided by the brachial pressure, and that gives you your ratio. The ratio is just an indication of the ratio of blood flow in the ankle versus in the brachial area. So I'll explain how this changes, but a result of between roughly 0.8 and 1.2 is thought of as probably they haven't got any significant arterial disease. A result less than 0.8 means they've probably got arterial disease, and then the lower you get, the worse it gets. The thing to keep in mind is that a number greater than 1.4 doesn't necessarily mean you've got great blood flow to your legs. What it might mean is that the artery is calcified and it's hard, and actually no matter how much pressure you're putting, you can't squish it. So you might have arterial disease, but you just can't squish the arteries very well from outside. So just to make that clearer, and also if this is still confusing, the YouTube channel 0 to Finals has a video specifically on this that's worth watching. It's really short and it's really, really clear. You check the blood pressure in the leg that you're interested in, the blood pressure in both arms, take the higher arm blood pressure, put that on the bottom, take the leg pressure, put it on the top, divide it and get your ratio. The lower the pressure in the leg that's required to block that flow, the lower the number you're going to get here, which indicates worse disease. Is that clear? It's just systolic. Just systolic, sorry. Okay, any questions about that? It's not an easy concept. Is this done in practice much? Actually, it is. It's done in practice a lot. I did a vascular job in my F1, and I swear half of the jobs were checking people's ABPIs before their procedure and after their procedure. It's actually done a lot, so it's really useful to use. The blood pressure cuffs that they use are also super fancy and have these massive dials on them. The other thing to keep in mind is that if you're continuing to increase the pressure and they still have blood flow, just stop. There's no point in going above 200. They're calcified and you're just going to hurt them. What are the normal ranges for ankle blood pressure? Blood pressure in the ankle is, oh God, I'm going to get this wrong. I think it's just slightly higher than it is in the arm. Everyone's blood pressure is slightly different. So I guess if normal blood pressure systolic is 180 in your arm, it's probably going to be highest 140-ish in your leg, maybe. Logan, do you want to back me up on this? Make sure I'm right. I will correct myself if I'm not. All right, I'm going to keep going. Okay, and then you get to your close. You thank the patient. You always thank the patient because they give you extra marks, which is great. You present your findings, so whether or not they had any pathology. You consider your differentials. In this case, your differential is going to be whether or not they had peripheral arterial disease, and whether or not you found something that you think might have caused it. So whether there are these clues around the patient, whether they've got those fingerprint pricks, and then also think about other complications they might have. So have they got the GTN spray? So not only do they have peripheral arterial disease, but they've got cardiac disease as well. So you've got your differential, your causes, and your complications. And then you think about further investigations that you can suggest. You always, always, always go from your bedside to your bloods, to your imaging, to other stuff. So you would do a cardio exam, a neurovascular exam, and a peripheral venous examination because the two usually go hand in hand. You'd suggest an ABPI if you haven't done it. You would ask to measure their claudication distance. You'd ask for an ECG in case there are cardiac problems as well. You'd ask for a capillary blood glucose, so an immediate one to check what their sugar is. You can also suggest that you might be fancy and do some fundoscopy, so you might look at the back of their eyes to look for any other indications of high blood pressure or high cholesterol. You would do a full blood count because if someone's anemic and they have poor blood flow, that is not great. You do use an EASE because you check for their renal function as well, because that can also be affected by the same processes. You check their lipids, so their cholesterol. You check their HbA1c, so you get a picture of what their sugar control has been like over the past few months. In terms of imaging, you would consider duplex or angiography. That's generally what's ordered. And you'd consider referring onwards to the vascular team. Right. How do you measure claudication distance? We don't tend to do that, but you just ask the patient how far is it you can walk before your cramps become so painful that you have to stop. And that would be their claudication distance. So you just say, I would measure it. You just go on a walk with the patient and figure out how long it is. If you want, you can formally get them to go down to classes with, I think it's with physios, specific vascular physios that do it. But generally you'll send them to the vascular team and they will sort out the specific distance themselves. Right, before I move on, any questions about the arterial exam? Okay, I'm going to take that as a no. Logan, thank you for checking about blood pressure. Oh, I see. Okay. So the peripheral venous exam, again, I'm going to go through some background information. I'm going to talk about varicose veins and how the venous system works. Then we'll go through the OSCE. Surprise, again, we go with the opening bit, the exam itself, any special tests, and then the closing part. So, varicose veins, what are they? They are abnormally dilated and lengthened veins. This is kind of what they look like here. 90% of them go along the course of the long saphenous, 15% of them go along the course of the short saphenous, and 5% have both. In terms of risk factors, so risk factors for primary varicose veins, so not really caused by anything else. Females, so females get it more than males at a ratio of 9:1. A family history, and pregnancies, which I guess you might be able to put under secondary. It depends on how you want to classify it. And then you've got your secondary causes of varicose veins, which are previous deep vein thrombosis, because that will damage your vein, it won't work properly, and it will get all enlarged. Pelvic pressure, so I've put this in bold because anything that increases pressure in your pelvis can reduce the ability of blood to flow backwards into your heart, and it can make it difficult for the vein to work how it's meant to work. So that can be anything from pregnancies, which we've put under primary because people don't like it being under secondary, but also things like cancers or increased abdominal pressure for whatever reason. You can also have them congenitally. You can also get an arteriovenous fistula, so a connection between the artery and the vein, or any severe tricuspid regurgitation. In terms of symptoms, people can have some pain, some swelling, especially around the ankle. It can be itchy, it can bleed. Generally, people are concerned because of cosmesis, because of how it looks. In terms of management, again, we have conservative, endoscopic, and surgical management. So your conservative management are things like elevating the legs, wearing compression stockings, losing weight, exercising, and then treating any secondary causes. You've got your endoscopic, so they stick something down it and they inject stuff in order to plug off the vein so it no longer works. So it's usually something called foam sclerotherapy. You can also do some radio frequency ablation, very clever stuff. And then you've got your surgical, which is pretty much cutting into the vein and blocking it off. Right. So varicose veins, how are they formed? You've normally, in this corner here, got your deep and your superficial system. The blood flow goes from the bottom of your foot back towards your heart. You've got the valves, which only let blood flow one way. And you've got the superficial system, which feeds upwards and also into the deep system. And the deep system, which feeds upwards, it all ends up in your heart. So the thing that goes wrong is you get increased pressure in the superficial venous system. For whatever reason, there is increased pressure in this system. These one-way valves, they stop working so well. So the veins don't, the blood doesn't flow correctly through the vein in the right direction. The other thing to mention is that whenever you're moving your muscles, so whenever you step, your muscles squish on these veins and force the blood through the one-way valves back up towards your heart. Really important when I start talking about the special tests, which are kind of complicated and difficult to understand. Right, there's less background here because I'm going to go through some more detail when we get to the special tests because it gets complicated. But the OSCE goes through your open, your wiper, your exam, your inspect, palpate, your auscultate, your special tests, and your closing. So your opening, again, it's wiper, wash hands, plus PPE, pretend that's there. Your introduction, so you introduce yourself, check you've got the right patient. Permission, explain what you're going to do and gain permission to do it. Expose the patient and reposition them. Inspection, generally. Patient might have some pain relief, they may have some walking aids if it's really uncomfortable. And looking at the patient generally, do they look well, do they look unwell, are there any obvious sequelae of disease? Then you've got your actual exam, your inspect, your palpate, and your auscultate. So starting just at the inspect part, You start with the patient standing. You look at them from top to bottom or bottom to top, but you've got to make sure that you look front and back and also medially and laterally, because you've got to look at the distribution of the veins. And then you palpate. But we'll go through the inspect bit first. So here you've got your veins of the leg. You've got to think about where it starts. It starts at the bottom here and it ends at the top. And these are the signs that you are looking for. Do you guys know what any of these are? So anyone for number one? Or 7. It does look like telangiectasia, number 7, it does. 1 is hemosiderin, really good. Number 2? It's venous eczema, yeah, it looks kind of dry and itchy. Number 3? Looks a bit thickened, that might be a clue. Yeah, good, lipodermatosclerosis. Number 4? Yes, number 4 is inverted champagne bottle leg. So what happens is you get this lipodermatosclerosis, this kind of thick and toughened bit of skin. You get it in a ring around the leg, and that makes the leg look thinner at the bottom. Not nice stuff. Right, number 5. Can you guys see it? Yep, that is the beginnings of a, or maybe even a healed venous ulcer in the gaiter area. So we call this bit the gaiter area. That's where you tend to get your ulcers. I didn't show an actual venous ulcer because they look a bit horrifying. You guys can Google it if you're desperate. Oh, sorry. This could be a venous ulcer, but actually it's if you look, it's got some red bits around it. So that's actually something called atrophy blanche. So it's the bits just before you start developing an ulcer. Number 6 is you got the beginnings of a venous ulcer there. These bits are stark white, so it's actually called atrophy blanche. Sorry about that. Number 7, so someone said it looked like spider nevi, which was really good. This is actually called venulictasias. So it's kind of like a spider nevi, but of the veins. Got venules everywhere. And then the last one, number 8, this is called ankle flare. It's similar to number 7, but it's kind of just around the ankle. So these are the kind of things that you are looking for. I'll let you guys take a screenshot of that if you want to. Cool. So stages of development of venous ulcers. I didn't want to include a real photo of it because it's nasty, but it can look like lots of different things at different stages. So this is when you start seeing the atrophy blanche bit. You've got the whitish areas of dead skin, and then you start getting the wound, the venous ulcers. Right, so you've done your inspect, you've looked top to bottom, front and back. You've had a look at them standing up, and you've also had a look at them lying down to look for any obvious venous insufficiency, thrombophlebitis, and DVT. I will show you photos of these when we get to the palpate bit. And then you palpate for temperature, you palpate for tenderness and edema, and you do it along the course of the vein. If they have a saphenopharynx, do you guys know whereabouts you would find that or what it is? So the saphenopharynx is the end of the long saphenous vein. Sometimes you can get a swelling in that area. It's found near the pubic tubercle. So up here would be your pubic tubercle. You go 4 centimeters down and 4 centimeters lateral, and that's where you would find it. It's a really common area of venous problems like backflow, etc. And it's one of the places that you look. And you feel for a cough impulse. So you have them lying down, you put your finger on it, and you ask them to cough. See if you can feel it. If you can feel it, it means that the veins above it aren't working properly because you're getting backflow of blood with this increased abdominal pressure. You can also do something called a tap test. So what you do is you tap over the saphenofemoral junction and you feel further down, or rather further up, further down as in further down the leg of the saphenous vein for any transmitted vibrations. So you shouldn't be able to feel anything further down because you should have the valves blocking it. If the valves aren't working properly and you tap up here and you can feel the tap down here, that indicates a venous problem. That is your tap test. And then I will show you what I mean by thrombophlebitis and DVT. No, I won't. Now I will. Okay, so this is what thrombophlebitis looks like. It's kind of inflammation of the vein, and your DVT. So this leg is much more swollen than this leg, and you squeeze it and it's very, very painful. This image here, I think, was to show you roughly the course of the venous areas, and this image here is to show you where the saphenous is. Okay, and then in terms of auscultation, you just auscultate any large vein clusters in case there might be a fistula there. Right, so before I start talking about the special tests, I just wanted to bring this to your attention again. You've got your superficial system, which feeds upwards into the heart and into the deep system. You've got your deep system, which feeds upwards into the heart. This bit here shows an incompetent, what we call a perforating vein. So these veins that go from the superficial to the deep part are called your perforators. If they don't work, you might start getting varicocele, you might start getting varicose veins because they won't be emptying properly. And then this red line here was me showing you where your saphenous might be again. So it's right at the end of the femoral vein up here. And in the light blue here, you can see the deep veins. So they go all the way up. They start at the lateral malleolus and then go in quite quickly and you can't feel it. And then you've got your superficial system here, which starts at your medial malleolus, goes up the leg. You can feel it in the popliteal area, and then it continues to go up the leg. Do you guys want me to go through the course of the veins in more detail? Or are you happy with it? Okay, no takers. Right, we'll move on. Oh, okay. Right, so these are the special tests that you do. The first one is called Trendelenburg's. It tries to figure out which part of the vein has valves that aren't working properly. So the patient's got venous incompetence, but you're not sure where it is. You lie the patient down, you lift their leg up, and you kind of squish all the blood that's in those varicose veins up through the system so they go back through to the heart. So you rub along from distal to proximal. So you rub from the ankle upwards as the patient is lying down with their leg in the air. You then apply pressure over the saphenofemoral junction with 2 fingers. Most people just stick a tourniquet on, and you ask the patient to stand. So you're blocking this bit here. If the veins refill immediately, it means that they're getting blood flow that's coming back from somewhere else within the system, so somewhere lower. If the veins only refill after you take the pressure off, it means that the incompetence, the backflow, is up here somewhere. So it's just telling you whether or not the incompetence is in this area or somewhere below it. So once you've figured out whether it's here or below, you then need to do the tourniquet test to figure out where the actual incompetence is. So where in this system is the incompetent perforator. The tourniquet test is basically the same as Trendelenburg's, except for you move the tourniquet lower. These little bits marked with P are roughly where the perforator veins are. I couldn't tell you myself exactly where each perforator vein was, but you start at the top, you milk the leg, you put the tourniquet on, you stand them up. you find that the veins are immediately refilling, so the incompetence is below that level. You then do it again, move the tourniquet down, get them to stand up. It refills immediately. You know that the incompetence is below that. So you do it again, you milk the vein, you put a tourniquet on below that level, and you stand them up. And you keep doing that until the vein doesn't refill and you found the level of the incompetent vein. It's a very long and laborious process. You are unlikely to have to go through all of it in your OSCE. They might ask you to explain how to do it. They might ask you to show it once if you're unlucky, but that's pretty much it. So that is your superficial system done. That's looking for your varicose veins. And then you can check your deep venous system. This is Perthes test. It can be quite painful if someone does have venous disease, so it's not often carried out. Here, you just slap the tourniquet on roughly at mid-thigh level. You get the patient to stand. You get them to hop up and down on their toes or flex their knees 10 times or kind of just bounce up and down. What you're doing there is you're activating the muscles and you're forcing blood upwards. But the blood can't go up through the superficial system because you've blocked that off with your tourniquet. So it has to go up through the deep system. If the deep system isn't working, they're in a lot of pain. And pain suggests a deep vein thrombosis. Right. Then you thank your patient to get those extra points. You present the findings. So what did you see? Were there any pathological findings? You consider your differentials, so whether or not they've got venous disease, suggest your further investigations. Again, always bedside to bloods to imaging to other. You'll say, I want to do a cardiology exam, a neurovascular exam, an arterial exam, an abdominal or genital exam, especially to look for masses, anything that will increase your abdominal pressure, considering sending them off for abdominal ultrasounds, etc. And you can suggest doing a Doppler, a venous or arterial duplex, because the two diseases usually come together, or venography. Someone wanted to see the last slide again. There you go. This image here is from the slide before. It's just to remind you of the connection between the superficial and deep system. So you're blocking off the superficial system. You're making them move their legs so the blood can only go up through the deep system. So if the deep system isn't working because there's a clot somewhere, it is painful. What sort of patient are we likely to see? Someone's asked, what sort of patient are we likely to see in the OSCE, a diabetic? It could be because people with diabetes can be relatively stable, so you might see someone who's diabetic. It's usually someone who is well with signs in your finals. At what time would we be doing Perthes test over doing a Doppler scan for DVT? Honestly, rarely. These aren't really done very often in practice. Generally, if you're worried about these things, you would send people for their imaging, or rather, a GP would see them because that's where the patient would present to. The GP would refer them onwards to whichever vascular team looks after them. The vascular team would do an assessment and order any necessary imaging that's required. Perthes test isn't carried out very often. All right, very, very last few slides. I wanted to go over ulcers very quickly because you get asked about this in your OSCE. The two ones that you need to know about are your venous and your arterial ones. These ones, super rare, you don't really see them very often. So the big differences are where they are. So your venous ones are in your gaiter area. They're usually lateral. They can be circumferential, so around the whole ankle, you'll start seeing some changes. The arterial ones are usually over the malleoli, so over the end of where the artery supplies, or over the metatarsal heads, or over the base of the fifth metatarsal. These ones, the venous ones, are usually large and shallow, and they're usually oval, and the margins usually irregular. Arterial ones are small, deep, and regular. They're usually described as being punched out, whereas the edge of the venous ones are sloping, so it kind of goes from deep to shallow slowly. The venous ones are slowly trying to heal, so there might be some granulation. The arterial ones, they don't have the blood supply to heal, so they look awful and sloughy and necrotic. This is actually a really good summary. If you guys want to take a quick screenshot of that. Actually, what I didn't mention is if somebody's got a deep vein thrombosis, they might come to A&E with that because it's really painful. So this isn't your superficial varicose veins. This is a clot in your deep venous system. This can break off and cause a clot elsewhere in the body, including in the lungs. So in that case, when they come to A&E, you don't do Perthes test on them. You send them for an ultrasound to look at these veins. You send them for a duplex or a Doppler. Right, quick quiz and then I'll let you go. Okay, so can anyone give me 3 risk factors for arterial disease? Diabetes, age, weight, good. Smoking, diabetes, obesity, yeah, fantastic. So your big ones are your smoking, your diabetes, your hypertension. What do you guys remember what the number for your ABPI for your critical ischemia is? Less than, okay, so less than 0.3 is generally your cutoff. Some people say 0.5 if you've also got these other symptoms that people are worried about. Anyone remember what those 6 P's are? Start with the one that the patient complains of first. Party, very good looking. Pain. Okay, pain is the big one. Yep, any others? So what else will the patient say? They've got paresthesia. They might even have paralysis. Good. You'll see that it's cold. You'll feel that it's, you'll see that it's pale pallor. You'll feel that it's perishingly cold, and you'll feel that it's pulseless. Right, does an ABPI more than 1.4 exclude peripheral arterial disease? Nope, good stuff. It can be calcified, so you can't squish it. Right, Berger's angle, less than roughly what angle is associated with severe arterial disease? Less than 20 degrees, woo! Okay, venous disease. The majority of varicose veins occur across which vein? Bit of a mean question because it's one of 2. Yeah, but which one? So 90% is in the long saphenous, really good. 3 risk factors for your varicose veins. Remember, primary and secondary. Pregnancy, yep. And along with pregnancy, what can I make you think of? Family history, yep, very good. Abdominal mass, anything increasing pelvic pressure, so it can be cancers. Yes, good, reduce, good, really good stuff. 3 signs. Do you remember the names of any of the signs of venous disease? Lipodermatosclerosis, yep, you have to make me say that one. Hemosiderin deposits, good. Atrophy blanche, really good. Champagne bottle as well, fantastic. Great, guys. That's been really fun.